Dear attendees and speakers to this session, I take this opportunity to very warmly welcome you to this session as part of the virtual conference of the Consortium of Universities for Global Health, to this special session that is co-organized by the Global Health Network and the International COVID-19 Data Alliance on addressing the critical gaps in health and development, specifically focusing on equitably harnessing the power of health data. My name is Michael Makanga. I'm Director of the European and Developing Countries Clinical Trials Partnership, and I'll be chairing this session. And I want to very warmly welcome you to this session. And before we start, I want to quickly take you through some housekeeping matters. First, I want to remind you that this session or this event will be recorded, and you will receive the recording after the event. All of you attendees have the opportunity to pose questions throughout the event using the Q&A functionality that is available. You are all encouraged to use the chat function to talk about where you work and what you do and share your thoughts and ideas. This meeting is aimed to inform the discussion. The sharing of this information is aimed to both inform the meeting and the discussion, but also to give us a chance to know each other. Now, moving on to the objectives of this meeting, we are gathered in this session to discuss equity, harnessing the power of health data. And you cannot agree more that time for action and collaboration is now. And the next 180 minutes, I believe, will be very well invested as we together explore how collaborations and strategic partnerships can harness the power of data to tackle the most devastating health issues. We will be drawing from the experience of the Global Health Network and also from the International COVID-19 Data Alliance and all of you partners that are present to actively and are actively involved in global health issues as we discuss this critical matter. At the end of the day, we want to advance collaborative research and ensure that everyone who participates in this collaborative research benefits from it. And at this point, I want to move on to introduce our speakers. We have an interesting and very well-informed lineup of speakers. And before I do, we have a polling question that is going to be displayed. I encourage you to respond to the polling question. I'll pause for a bit as we see how this turns out. Please look at the following list and select the most frequent barrier researchers may encounter in your setting that prevent them from doing their own research. From what we can see, 74% of you are indicating lack of resources, and this refers to financial, human, and infrastructure to support data management. This is followed by all the above, which includes lack of training and or experience, which is sitting at around 11%, and lack of access to health research literature, sitting around 3%, and limited collaboration or isolation, sitting at 10%, and others. So we are really geared up to having a very, very fruitful discussion or deliberations today. So with this, I take the opportunity to introduce two of our opening speakers. These are two speakers that are our hosts as well. We have Professor Andrew Morris. Professor Andrew Morris has been the inaugural director of Health Data Research UK since August 2017. Health Data Research UK is the National Institute for Health Data Science with a mission to unite the United Kingdom's health data to enable discoveries that improve people's lives. Andrew is seconded from his position as Professor of Medicine and Vice Principal of Data Science at the University of Edinburgh. Welcome to Andrew. And our second speaker is Professor Trudy Lang. Trudy is the Director of the Global Health Network, a Senior Research Scientist in Tropical Medicine at Nuffield Department of Medicine, and a Research Fellow of Green Tempton College. Trudy has a wealth of experience ranging from her expertise from industry, academia, and has had the opportunity to work for a long time in low and middle income countries, as well as high income countries. So when we talk about collaboration, these are two sets of people that are well equipped to give us the opening addresses. So over to Andrew.
Well, good morning, good evening, good afternoon, everyone. And what a great privilege and a pleasure to be invited to contribute to this symposium. And thank you, Michael, for chairing it. And I should say to everyone, happy March. It's the 1st of March. And I should say that from here in Scotland, we had 3 feet of snow 2 weeks ago. So we're hoping that the springtime is coming. The 1st of March is also the anniversary of Frédéric Chopin's birth, who you'll recall that Chopin was a Polish composer, very famous for piano concertos. And I think the program we've got lined up this afternoon is going to be a fantastic concerto of amazing global talent. And we're very privileged to be part of it. But we also have to reflect on a somber note. You know, today the WHO report there are 113 million confirmed cases of COVID-19 and 2.5 million reported deaths internationally. Clearly, that's probably an underestimate. And sadly, in the UK, you know, we're struggling with this pandemic. We're not doing very well. 5% of those deaths, 123,000, have been in the UK. So we've got a lot to learn. Secondly, we're facing a unpredictable phase of the pandemic in relation to vaccine availability and access, vaccine effectiveness, safety, and the impact of variants on the pandemic. But as we know, the best way to control the pandemic is to suppress the virus everywhere at the same time. So that's why meetings such as this are so important as we learn from each other, because only if we have a global learning health system will we actually be able to suppress the pandemic. And for more than a year now, many countries have successfully controlled transmission without vaccines. showing the power of public health measures. So vaccines are only one part of the puzzle. And if we are going to learn, we're going to need to unleash the power of data in a trustworthy way, in a transnational manner. And that's the theme of this conference. And just to echo Agnes Binaguajo, who chairs our scientific advisory board, she says there's a need for the evidence-based decision-making across institutions, across nation states, and that requires data sharing. And a lack of data sharing jeopardizes the effectiveness of the pandemic response and may not only hamper our current response, but also to future threats to human health. So undoubtedly there's an opportunity, and that's where the International COVID-19 Data Alliance aims to contribute and to make a distinctive contribution by working in partnership globally to unite health data in a trustworthy way, improve it, and then use it to address not only this pandemic, but other future health challenges. And we're in the foothills of where we need to be, and we need to learn. And the program today will be a great opportunity to look at global best practice on how data has been harnessed. If we're going to succeed in this, values and trustworthiness are going to be absolutely vital. If we're going to address the lack of equity in health data research internationally, if we're going to address the low levels of trust that often exist, and if we're going to harness technology, infrastructure, data standards at a global scale, then we'll need to work in partnership. Next slide, please. Oh, that's the wrong way. So our approach has been to build a collaborative alliance that is inclusive. Secondly, to try to develop and maintain a trustworthy data ecosystem, putting public and patient engagement at the heart of everything we do. Thirdly, to be transparent around data stewardship. So it's safe in terms of the data, the projects, the people, the settings, and the outputs are safe. Fourthly, to have global representation, and hence I'm thrilled to be contributing and speaking shoulder to shoulder with such a distinguished panel. Fourthly, how do we harness technology so it enables trustworthy data access and sharing at scale? And lastly, how do we address the interface between the stewardship, the policy, the governance, the infrastructure, and the research questions, so that any international endeavor is research-led? And we have a driver project methodology of trying to fine-tune the infrastructure. It's a method that we borrow unashamedly from the excellent Global Alliance for Genomics Health. So this agenda is bold, it's ambitious, it's enterprising. I'd like to thank so many people, Agnes Binaguajo, Effie Viana, who chairs our Ethics Advisory Board, my colleagues today, as well as our funders, the Gates Foundation, Minderoo, and the Wellcome Trust. We look forward to working in partnership with you. And as Mandela said, it always seems impossible until it's done. And I think the time is now to try to address some of these knotty and thorny issues around trustworthy sharing of data internationally. And I'd now love to hand over to my good friend and colleague, Trudy, who will outline how we are working in partnership and learning from the Global Health Network. So thank you.
Thank you, Andrew, and thanks, Michael, for the introduction. And also thank you, everyone, for joining today. I can see we've got over 300 participants at this event, which is just incredible. And this is hopefully a starting point of working with very many of you. And the whole point of what we hear a lot from today is about working together and forming some new alliances and collaborations. So I want to step back a bit from COVID and the pandemic, and I want to look at this a little bit in the sense of the whole ecosystem of research and how we end up with data. So the Global Health Network started, well, at least 12 years ago, more than that probably, in East Africa. And it's great to have EDCTP taking part so strongly today, because largely this is a result of the work we were doing in those early days with the European Clinical Trial Development Platform, trying to set up networks of excellence across Africa. And I know you're going to hear more about that later. And what we were all recognizing, that those of us working at that point, was that the difficulties in putting health research in place in the first place weren't related to what disease you were working on, where you were based, or whatever even your role was in health research. The things that make health research difficult don't vary between those things. And there's actually most of the difficulties and barriers are really common. And so what we set out to do in this open collaboration from the very start was just to try and bring together the skills and the knowledge that anybody would need to run a good health quality research study wherever they were in the globe and whatever support they had. So this was all around trying to bring access to the training, the tools, the knowledge, templates, protocols, so that anybody anywhere could run a health study. And we're talking about all types of health research studies here, not just clinical trials, but we've learned definitely from Zika, you're going to hear about again later, Ebola, and of course now COVID, that all types of health research data are important if we're going to learn how to characterize diseases, understand the threats, and then test and implement interventions to address them. So this whole health research system is just so important. And if we do turn our minds back to pandemics and obviously mitigating to the next one, I think many of us think quite strongly that there's really no point to talk about preparedness for research or implementing research for an outbreak. Actually, we need to have research there every day to work on everyday diseases, that if you have teams in place who can collect data, who can work to gather evidence, then you have the preparedness in place, ready to respond and pivot to an outbreak. So the Global Health Network started all those many years ago, and it's evolved over this past decade or so to having these two sides to what's delivered through this platform, but also on the ground. And lots of the people you're going to hear from today work really closely. They're partners of the Global Health Network. This is an open, free global alliance that many, many people take part in. And the whole idea is, on one side, the Global Health Network offers this capacity development, how it all started to bring tools, templates, training and resources to anyone wanting to undertake health research, whatever their healthcare setting they're working in. But that quickly devolved to groups wanting to come along and have their own hub on this. So it evolved into this science park analogy we often use. And so within the knowledge sharing hub, and I invite you later on to have a click around and go and have a look and see what you can find. But there are over 50 hubs part of this whole network now. And each of those may be working on a disease area, malaria, Zika, Ebola, maternal health, malnutrition, or they might be working on a type of skill or area of research, health laboratories, genomics, community engagement, ethics. So we've got this really nice cross-cutting forum where people are sharing information and how-to between diseases, regions, roles, careers, organizations, across geographies, across boundaries. And this is all around trying to make research easier and faster and more accessible wherever you are and whatever the healthcare setting you work in. So the whole point of the Global Health Network is trying to raise awareness and engagement in research and try to create some equity, as Michael referred to earlier. It's really wrong that here we are at this point in time where we still have that 90% of research only benefits 10% of the population. And if we really want to make that switch, so that just isn't the case going forward, then it's really important that there's this ability for anybody to run research wherever they are and to build lasting, capable teams. And if we have these lasting, capable teams in place, then they can be internationally competitive and they can do this ongoing research every day, working on the diseases that impact them, and then pivot to respond if there's an outbreak. So I'm really excited to hear all the talks today, and Andrew and I will come back at the end. And what this hopefully we managed to convey is this linking up of the whole health research ecosystem, from gathering the evidence, running good studies, and then having data that can be shared and more questions can be answered of that same data over time. So back to you, Michael, and thank you everyone for taking part today.
Thank you very much, Trudy, and thank you, Andrew, for the opening, insightful presentation that you've made. Indeed, values and trustworthiness are critical, and having the capacity that is really well built, irrespective of location, is really the bedrock of sustainable development. And in this case, I want to take the opportunity to invite the chair of our next session, Dr. Alia Nahid, who is going to chair our next session on setting out the challenge. Dr. Nahid is the head of the Initiative for Non-Communicable Diseases, Health Systems and Population Studies Division in Bangladesh. Over to Dr. Nahid.
Thank you, Dr. Michael Mukanga. It's a pleasure to join this wonderful conference and meeting so many people. And I'm so thankful to ICODA and the Global Health Network for organizing this wonderful session at a very timely way. So I'd like to remind our audience that this session will now be having brief introduction from our panelists. So we will introduce our panelists, and you will have an opportunity to ask questions in your question answer box. Please don't forget to ask your question in the box. And I would like to introduce you to our panelists. Our first speaker, Dr. Jacqueline Alger. We have three speakers. So our first speaker, Jacqueline Alger, is a faculty member of the Faculty of Medical Sciences, Universidad Nacional Autónoma de Honduras. So she is a faculty member in the research unit of the faculty of this Autonomous University of Honduras, and she is also a parasitologist working in the Department of Clinical Laboratory at the University Hospital, the main public health hospital in Honduras. So we're very much looking forward to hearing what Jacqueline Alger would share with us. Over to you, Dr. Jacqueline.
Thank you, Dr. Nahid, and thank you for the opportunity to contribute to learn from this session. I will touch three aspects. First, I will share insight from the research landscape in Honduras. Second, I will describe the barriers I have identified. And third, I will focus on the importance to address these barriers and move forward. I have been able to know and experience the research landscape in Honduras from different angles. As I work in the main public university and also I work in the main public hospital, I collaborate with a not-for-profit private foundation, and I also collaborate with the Honduras Medical Association. By interacting in these different spaces, I have been able to get in close contact with pre-grad and postgraduate students, faculty, and health professionals of different profiles. Let's see some of the barriers researchers face that I have identified. First, we need to remember that Honduras is one of the poorest and unequal countries in the Latin American and the Caribbean region. Also, importantly, human talent is fragmented in our institutions because personnel have had to have 2 to 3 full-time jobs to cope with living standards. Then a full-time or part-time journey of 3 to 6 hours is not enough to develop and sustain a fruitful research environment. Also, there is a lack of adequate data management. There are no well-equipped data centers, nor the trained personnel for data management. Physical clinical charts are frequently lost or incomplete. There is also a limited opportunity for research mentoring This is an important informal way to advance research, and this important mentoring has not been fully developed. Well, however, it is important also to highlight that there are some strengths and opportunities that could lead to overcome these barriers. First of all, there is a great deal of interest for research among students and young professionals for many reasons, as graduate requirements, to be competitive for the postgraduate programs, to have a better opportunity for a job post, and also for a genuine interest to contribute to generate knowledge. Also, there are some important elements of a health research system that need to be improved, but importantly, they exist. These include that there are regulations describing research structure and functioning. There are also formal spaces for research dissemination, including peer-reviewed journals and annual scientific events. Research priority exercises have already taken place, and many departments and postgraduate programs have a research agenda. Research is a graduation requirement for pre-grad and postgraduate students, including clinical specialties and master's program in epidemiology, public health, and nursing. Of importance, there exists a long-standing international networking, providing opportunities for training and collaboration, including online resources, now so vital during the COVID-19 pandemic. There is a significant number of students and young professionals from Honduras taking online courses, visiting virtual spaces, and participating in global initiatives. Then, taking into account all of these strengths for research, what happened? Is it possible to move forward? Well, I believe we need to identify research as part of the solution for tangible problems in the provision of healthcare, in the prevention of diseases, in the well-being of communities, in the academic life, and environmental protection and sustainability. Quality and ethical research and social innovation for health have important role in putting into action the Agenda 2030 for sustainable development. The generation of data is a first step to provide better care and treatment, as well as to advance more effective health services. Furthermore, in pandemic time, there are additional barriers to overcome. So, how to address the basic challenges of generating data in Honduras? Well, there are several ways, efficient and innovative ways to address these, and we will learn of some of them in this session. In Honduras, moving forward from the identified strengths and the opportunities placed by networking and collaborating, focusing on data generation is a fundamental first step in the journey of harnessing its power. Thank you.
Thank you, Dr. Alger. It was lovely hearing your experience. So our next speaker is Dr. David Mukanga. He is a Senior Program Officer, Africa Regulatory Systems at the Bill and Melinda Gates Foundation, where he leads the foundation's Africa Regulatory Systems Optimization portfolio. Dr. David supports the development of harmonized, transparent, and predictable regulatory systems covering the life cycle of medical products in Africa, as well regulatory emergency preparedness. In this role, he works side by side with partners on the African continent, and I am very happy to introduce him before the audience. Over to you, Dr. David Mukanga.
Thank you very much, Dr. Nahid. And it's my pleasure to have this opportunity to interact and chat with this very august group. It's a real pleasure, and I hope you're keeping well. So I will talk a little bit about my role at the Gates Foundation and some of the the areas that we're trying to address to improve the clinical research ecosystem on the African continent, the challenges in the space, and how we're working with partners to address those. As you all know, Africa has a population of about 17% of the world's population, but is only host to 2% of the clinical trials that occur globally. There are several reasons that account for this unwanted situation. There is a lack of visibility into the capacity and capability of trialists and clinical trial sites on the continent. There's been for a long time an unpredictable and non-transparent ethics and regulatory ecosystem. Suddenly, issues around funding for R&D that are constrained, and many others that you'll hear today. My work at the Foundation is focused on moving Africa's ethics and regulatory environment into a more efficient, transparent, predictable, and much more harmonized one. Through the Africa Vaccine Regulatory Forum, we have supported development of harmonized, transparent, and process requirements and promoted capacity development through work sharing activities amongst regulatory authorities and ethics committees. The Average platform offers product developers a single review by ethics and regulators of their clinical trial applications. In 2020, a product sponsor was able to secure approval for 90% of 13 countries that participated in a joint review of a COVID product within 30 days. The actors from the 13 countries included not just regulators, but national ethics committees and institutional review boards. This is groundbreaking anywhere in the world. We have seen during the COVID pandemic that it's possible under these emergency situations for a regulator to review and make a decision in a matter of days, as we have seen in the US and elsewhere. But we've not seen that scale for a variety of multiple number of countries when bringing together both regulators and ethicists together to review a protocol and make a very rapid decision, as we saw with this particular example. We think that we can build on this progress and explore with Africa the opportunities and the possibilities for a single review and authorization system, especially for product development during emergencies. Our work with the Accelerating Excellence in Science in Africa, the IESA program under the Africa Academy of Sciences, to create a single shop, what they're calling the clinical trial community, to provide information on clinical trial sites, trialists, regulators, and ethicists will become an important feature in this space for advancing clinical research and data generation. We encourage you to visit this site if you haven't already done so and provide your feedback and inputs as it is being developed and finalized. We believe that this platform will advance visibility into the ecosystem and really connect trialists, trial sites, researchers, regulators, and ethicists on the African continent with their counterparts and sponsors and others in the global north into the space and really advance, the further growth of the clinical trial space on the African continent. We cannot address these gaps alone, as many of these challenges sit outside our individual spheres of influence, whether we're in academia or research or in the regulatory space or elsewhere. In trying to create transparency and predictability with regulators, we need the regulators in Africa to talk amongst themselves and with their colleagues from the outside about these issues. We need forums that bring them together to define their own priorities and their own key performance indicators. We need others like the WHO to define and to disseminate best practices that inform these priorities and these key performance indicators. We need others as well to help to track these indicators with researchers, with industry, as well as with regulators. And we need others as well to fund parts of this work. We need researchers and research networks to speak about the challenges they face every day, as we're beginning to hear today. And we also need industry and PDPs, product development partners, to articulate the barriers that they face and where progress is being made and where progress is not being made as rapidly. None of these actors And none of us can create a viable, attractive ecosystem on our own. As Bill Clinton said, "We are in this together" is a far better philosophy than "we are on our own." Thank you very much.
Thank you, Dr. David Mukanga. So it is wonderful to hear how the African group has put some regulatory process in product development. And of course, we need to unite all the researchers from all parts of the world to share their experiences to get fast-track solutions for the world. Thank you very much. So it's my pleasure to introduce our third speaker, Dr. Carla Sáenz. Dr. Carla Sáenz is responsible for the regional program on bioethics at the Pan American Health Organization, which is WHO's regional office for the Americas. Dr. Sáenz gives technical cooperation on bioethics, which includes support for the incorporation of bioethics into national and regional plans. I think this is a very timely speech from Dr. Sáenz after our session of Dr. David Mukanga. Over to you, Dr. Carla.
Thank you, Dr. Nahid. It's my great pleasure to be with you today. Thank you to our colleagues at Oxford organizing this meeting, because it provides us an opportunity to give to share a reflection from PAHO, from the Latin America and the Caribbean area. I think that we have to pause for a second and think that because of the global nature of the COVID-19 pandemic, we have been in an unusual situation. And that's that there has been very little need to share. To the extent that all of us have had cases and samples and data on COVID-19, I think we were unusually in not that much need to talk about sharing. We all had access to the same, unfortunately. But I think this meeting is extremely timely because I think that the conversation that we will have, that will escalate now, is the conversation about data sharing. New variants in different locations, populations starting getting immunized, brings a discussion to on data sharing to the forefront. Sharing is now crucial, and data sharing is the most important conversation for us to have, not just regionally, but globally. The regional program of bioethics has, as it were, a motto, which is that we're here to catalyze ethical research. And that's research that is beneficial for our populations. And this is how we organize all the work we do. And I think we forget sometimes that the last emergency, public health emergency of international concern, was in the region of the Americas, the Zika outbreak. And that allowed us the opportunity to learn a lot about broad consent, to actively promote the use of broad consent to use data and samples in future research, and to have a more open conversation about sharing, and also to anticipate future needs. So we could take a step back and plan from the get-go for future ethical use of data, for future sharing. And I think that overall, we've learned a lot, and we have stronger national research ethics systems. But there's a lot of work to do. We haven't talked much about sharing, and I think we have to acknowledge that this is a moment, at least for Latin America and the Caribbean, where the conversation about sharing is a difficult conversation to have. Latin America in particular has hosted and continues to host several COVID-19 vaccine clinical trials. The region has done a remarkable contribution to vaccine research, but is still getting very little and very slow return in the benefits that resulted from that research. So now at this point, what we want to make sure that happens is not just sharing, but fair sharing. And that's what we need to make sure that we ensure now. And as I said, it's a difficult conversation to have, because at this point, the perception is that there hasn't been that much fairness in this sharing. Our contribution has not encountered the return that we had anticipated, at least not this early. And we know that sharing requires trust. Fair sharing requires trust in our capacity to get those returns that are fairly owed to those that contributed. And trust is has been in limited supply during the pandemic, even taking into account, even forgetting about the vaccine trials and the resulting vaccines. PAHO conducted a study that I shared in the chat a moment ago about clinical trials. And while we've been amazed to see, and we think this is a result of our experience through Zika, we've been amazed to see the incredible effort, that the high amount of studies being done in the region very quickly and with appropriate ethics review and regulatory oversight in the pandemic. We also realize that the majority of them, in the majority of cases, we're talking about really tiny clinical trials, and not even within one institution, not even within one jurisdiction. We have managed to team up, to work together, and to make sure we conduct the studies that really make a difference. So I don't think this has been a problem of ethical nature or regulatory nature. I think we need to learn to work together, and some of the strategies that Dr. Makanga was suggesting earlier are really important for us to consider. So at this point, we face the need to advance fair sharing. There are some regulatory hurdles, there are some ethical hurdles, but I think there's some practical hurdles that cut across too, and we need to work on that, on our capacity to advance fair sharing. And I think that enhancing our capacity, for example, to produce and use strong transfer agreements that advance fair sharing of data and of course samples is essential. And I think that efforts like this one really help us do the most that we can in this circumstance, in which I think we need many things we know, but we also need new solutions. We need creative mechanisms to really advance the type of research and sharing that is needed. Thank you.
Thank you, Dr. Carla Sáenz. So it was really wonderful to hear your perspective about working together and a very important aspect of bioethics in clinical trial. So very enlightening experience to share with our audience. So I want to remind our audience that there is a question and answer box that we'd love to get your questions. And our next session will be the panel discussion. So I'd like to take the privilege to ask a few questions to our panelists, if that is okay with you. So my first question is to Dr. Carla Sáenz, who just finished her talk. So my concern is, why are regulatory and ethics requirements at country level not public available, and how can the global health community facilitate improvements in this regard? Dr. Carla.
The ethical and regulatory frameworks and tools should be publicly available. I understand that that's sometimes not the case, but I think for the most part they are. But I think the question picks on a very important issue on which we have realized we are still behind. We need more transparency in all our research efforts. We need to make sure that not just the ethical and regulatory frameworks are available, but that at least all research with human subjects is publicly available for the population. It's very easy to say we need trust in research, but we need to see what are the things that we need to do at all levels to advance trust in research. We need better registries of clinical trials, of research overall. And because of that, we started working also communicating towards the population, with the population about ethical issues. And I shared the guidance documents that we produce, and there's one specifically on transparency that may be transparency of research that may be interesting. Thanks.
Thank you very much. So I have a question for Dr. David Mukanga. So I'm curious to know, what lessons have you learned that have global relevance on promoting generation of evidence that translate to decision-making during this pandemic and under other circumstances, particularly from the perspective of Africa's? Thank you. Dr. Mukanga.
No, thank you very much. An interesting question. Often a lot of the time, Africa and a lot of the LMIC countries, we have been receivers of good practices and best practices and lessons. And, I think over the years that is starting to change. And I think it is excellent that, both, all parts of the world, generate new ideas and new knowledge and learn from each other. I mean, in terms of the work that we have done on the African continent and this regulatory space with partners, and a lot of this work is driven by the WHO, by the African Union, by the countries themselves. I think the early lessons that, to be able to build and bring these coalitions together is really, really critical in terms of trust building. A lot of these things are not possible without creating the trust and building that trust, first amongst the regulatory authorities and the ethics community, ethics committees that come together and define, how they want to work together and so forth. So for me, that would be a first. It's in terms of just how you build that trust among these groups and build them as coalitions. And then secondly is really to be open and really engage with the developers and see them as clients, who are going to use the services. So whether those are PDPs, whether those are researchers within the African continent, whether those are industry, it's really, really important that that is done. And we began to see a lot of that, these networks are opening up and, engaging and explaining themselves and explaining their processes and getting input into the way that they work. And, even when they have new ideas and concepts, so they're putting them out and getting public comment into those processes. So for me, those would be the fundamental lessons there. I think some of these are not really new, they're happening elsewhere, but I think, with an African flavor, it's been very, 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 very enriching and informative. Thanks.
Thank you, David. That was really helpful. I think for the panelists, my last question would be to Dr. Jacqueline Alger. I'm interested to know Jacqueline's perspective about the Zika epidemic in 2016-2017. Do you think that epidemic offered opportunities to identify research gaps and strengths and provided key information for the COVID-19 pandemic response? You are muted, Dr. Jacqueline. You have to unmute yourself.
All right. Sorry about that. Yes, indeed, the Zika epidemics in Latin America and especially in Central America and in Honduras allow us to learn about working virtual communication, speed up some virtual communication and virtual community interchange, taking developing online courses and using virtual tools such as the intergrowth, that were very helpful. And although they were used for research, they were also introduced into assistance, clinical assistance, to teach in the academic environment of the hospitals. So I would say that the epidemic, the Zika epidemic, allow us to be prepared to the next epidemic, now the COVID-19 pandemic. But we still we have some barriers that we need to overcome. Thank you.
That was very helpful. Thank you very much. I'm just looking at the question answer trail, and I found an interesting question. The question is asked by Ian Niddleman. How do we develop meaningful public involvement or co-creation in research design in multinational studies? I think this is a very common question for any researchers, particularly in a pandemic situation, that one country cannot work alone, and we need to team up with as many groups as we can. So this is an open question to all the panelists. I'll be happy to get a response from any of you. Thank you. So let me repeat the question. How do we develop meaningful public involvement in research design in multinational studies?
Ali, I'll jump in while the others are thinking, and I'm sure we could have also some responses from the audience, because I'm sure many people on this call have a lot to say about this. Public and community engagement in research is absolutely critical, and there's some great initiatives going on around the globe to make sure that there's public engagement from the get-go when thinking of a question to designing the protocol, and then of course even taking the findings back into practice. I think that one of the next speakers is going to touch on this, but I can certainly point to, I'll put some links up on the platform of some great initiatives that are doing this. And it's also part of the WHO's remit. The director for research in the WHO is working on quite a significant project to really embed research into healthcare delivery and make sure that the community is involved in every step. And I think, again, sharing best practices in this and sharing experience on making sure that community engagement happens from question setting is really important. But I absolutely invite the panelists to chip in.
Well, I would like to comment that the Social Innovation for Health Initiative have identified very innovative and very helpful initiatives from Latin America, I would refer, but there are others in the rest of the globe to respond to the Zika epidemic. We have examples in Brazil and also in Colombia involving mothers and parents and rest of the family with the children affected by the congenital Zika syndrome. And we have seen also the telemedicine project, like in the Mosquitia in Honduras, giving answers to the communities, pushed by the communities to have access or to reduce the barriers to the access to the healthcare. So these community engagements through the Social Innovation for Health initiatives are very interesting, and they are identifying and highlighting how the communities respond, sometimes with very innovative and the right responses that are needed. Over.
Thank you, Dr. Jacqueline. I think we are almost coming to an end of the first session, but I am very tempted to ask my last question to Dr. David Mukanga. So I think this is about how he has managed the collaborations in African groups. So Dr. David, do you want to share with us your perspective, how you have been successful in organize these groups in Africa?
Thank you very much. I don't want to, neither I nor the foundation, I think, should claim any of that success. I think a lot of this work has been driven by multiple players, a lot of them African institutions. For example, the platform that I described earlier, the Africa Vaccine Regulatory Forum, the EDCTP was very much a part of the formation of this platform in the 2006, 7, 8. The foundation started supporting this platform a little bit later, after the EDCTP, and there have been many, many others. The countries themselves, these were homegrown ideas that, partners like us only came in and provided, financial support and some thought partnership. But also on the broader life cycle work, groups like the African Union Development Agency, the regional blocks in East Africa, West Africa, Southern Africa have been very much at the center of driving this work. And then, groups like the WHO have provided a lot of technical support for this work, and other regulators and other partners from other parts of the world, regulators from Europe, from the US.
I think David might have frozen. I think maybe Carla did want to come back on that last point, so maybe we could come back to David in a second and let Carla.
Idea, imposing ideas.
Thank you, David. We actually lost you for a few seconds, but maybe Carla can chip in before we wrap up the session.
Yes. Well, I was thinking about the previous point that was made about community engaging and going back to the community, and I think that has been a tremendous lesson for PAHO and the World Health Organization. I think that we often catch ourselves saying certain things, and we realize that we have to start doing things differently. So for the first time in the last 10 years I've been in charge of PAHO's bioethics program, we started actually producing material for the public on ethics of research. And this is an excellent time for research ethics, because now it's not just the researchers, it's not that the health authorities, it's not just the committees talking about research, it's all the population, and we have to get this conversation going with the broader community in terms of also telling them what ways are there out there to ensure that they get their fair return for research.
Thank you, Carla. That was very helpful. So we are actually coming to the end of session 1. We have 3 more very vibrant sessions to be presented by wonderful panelists. So I'd like to thank all the panelists for session 1, and the discussion was very helpful, and we got a lot of interesting questions in our chat box. So I'd love to, it would be great if we could ask all these questions to the panelists and get responses, but due to time constraint, we will probably record them and share our answers with you later. So without further ado, I would like to conclude the session. We will begin the second session in a few minutes. Thank you very much.
Thank you very much, Aliyah, for chairing this part of the session, which has been very, very insightful and very stimulating. And at this point, we are now going to move on to our next session, which really dives into the real world experiences, even before the advent of the current COVID-19. And to lead this session is Dr. Mukanga, David Mukanga, and I'm hoping that David is connected. David has already been introduced. David, as you know, is the Senior Program Officer responsible for African regulatory systems at the Bill and Melinda Gates Foundation. And over to David.
Thank you very much, Dr. Makanga. And I am back, I'm on the line. I had a little power cut and disruption here, but I think I'm stable now. Thank you very much. And we're now going into the second session. I would just like to let the audience know that we will hear the first two case studies, followed by a 10-minute comfort or coffee break or, biological break. And then one case study will follow after the break. So two case studies and then a break and then one after that. I will now take the pleasure to introduce the panelists or the case study presenters for this session. We have three of them. And I have the pleasure now to invite, I will introduce all three of them at once, and then we will take the case study from the first, if that is acceptable. So we have Dr. Aliyah Nahida, who just chaired the last session. She's a medical doctor with more than 25 years experience in health-related research in communicable and non-communicable diseases. Our second speaker is Dr. Louisa Lorenko, who is Regional Director for the RED Network out of Brazil. Louisa is the Brazilian Regional Coordinator for RED, a network focused on research capacity building in Latin America and the Caribbean. Louisa completed her bachelor's degree in biology and master's in oncology in Brazil, and then moved to the UK, where she obtained her PhD in oncology from the University of Oxford. She then returned to Brazil, and she has been working on several fronts to improve health research and education. And our last and certainly not least, our case presenter, our speaker, is Dr. Thomas Nyirenda, who leads the strategic partnerships and capacity building efforts as manager at the EDCTP. He's a public health physician and research scientist with 26 years of experience working in sub-Saharan Africa. He trained in medicine at the University of St. Andrews in Scotland, at St. Mary's Hospital, London, and the College of Medicine in Malawi. He did his public health training at the London School of Hygiene and Tropical Medicine before joining the EDCTP in 2014. So you're all very, very welcome, and we're really delighted to have you. So I will now invite Dr. Aliyah Nahida to present the first case study. Over to you, Dr. Nahida.
Thank you, David. That was a wonderful presentation. Sorry, let me come back to my slide. So what I will present is the situation in Bangladesh, focusing on a special population and how data can be the solution for protecting the future of Bangladesh. So if we look at Bangladesh, where this is, it is in South Asia. Those who may not have been in this region, you may know that Bangladesh is a very small country, almost pressed by two countries like India and Pakistan on both sides. And there's a big neighbor, China. So it is almost invisible. But if you look at its population size, it's one of the most dense country in the world. And right now, this country is bearing the load of 160 million people. So more than 30% people live in urban areas. But the healthcare is very expensive. But total health expenditure per GDP is 3.5%. But the irony is the healthcare is mostly out of pocket, 63% of the total health expenditure. So you can imagine that people bear a lot of burden. But where does this healthcare is going and who is actually benefiting, how people are affording healthcare. That's a big question, and particularly in COVID situation, this is a big question for everyone. So if we look at the population pyramid, this population in this country is rapidly increasing. So when in 2011, there was only 6.5% of population who were 60 years and older. In 2021, that increased to 8.2%. And this continues going up. And the projection, global projection shows that by 2050, the people of 60 years and older will predominantly overcoming the younger people, like children less than 15 years, will not be as many as now, and there will be 15 times more older people in this country. So this is a concern. The reason is these older people do not have very conducive healthcare access, and we have very limited information, almost none, about how people are in Bangladesh doing in terms of health when they become old, when they do not have any means to spend from their pocket for their own treatment. A national survey conducted in the country found that people often suffer from multimorbidity. So there are so many diseases they suffer, but when you looked at the major diseases, like chronic diseases, we found that out of diabetes, hypertension, depression, and dementia, more than 80% people suffer from at least one disease of one of these combinations. So people suffer, like 50% people suffer from a disease, and they really go to health providers to get treatment. But this is questionable what kind of healthcare providers they go to and where they get these financial resources. Definitely this slide shows that they depend mostly on their children, from their children's savings or earning. And we still see about 30% people, despite being in older age, they actually try to earn for themselves because they have no one to provide them livelihood. So if we look at the quality of care, this is very poor that the data suggests. If you take this example and how Bangladesh should look in 2050, we will see there will be more than 200 million people, and more than 21% of the people will be elderly. So there will be more burden in the society and who do not have the means to have good living or healthcare on their own. So age dependency ratio will be very high, raising from 7.7% to 23%. So this is quite concerning. So if you look at these people who are really helpless at the moment, we need rapid solution. But these people are the reflection of Bangladesh at the moment. Because if you look at the healthcare issues with younger people, those who are 25 years or older, the risk factors for non-communicable diseases is still very high in this population. So what we really needed to understand how this healthcare system is laid out and what are the risk factors that people really need to address for having good life and good health. There are limited opportunities in the country where we get routine data, such as the organization where I work in the ICDDRB, or International Center for Diarrheal Disease Research. This organization is reputed for running the longest health and demographic systems in Bangladesh, I think in the developing country setting. But that's limited to health and demographic data. But we need comprehensive health data from representative population to generate evidence that will give us immediate information to identify solutions. And for that, we need a lot of capable resources, and we need to create infrastructure for accessing data. But if you look at other side of the story, there are hundreds and thousands of hospitals in the country, and there is no such system that to get precious data that has been wasted every day. So this is really important to understand what is happening at the severity of the diseases for people at all age, and what would be the real-time service delivery system for the country so that everybody can get universal health care. So considering that, a group in ICDRB actually created a clinical research platform combining several hospitals in the country. And this initiative was a tripartite action across the postgraduate premier medical university in Bangladesh and the British Medical Journal. So the goals of this creation of clinical research platform was to develop a standardized common set for clinical research, bringing the clinicians and the public researchers around the same table, giving them opportunity to learn how to design research, how to design data collection tool, and do analysis on their own data to disseminate the results in real time. So this is a very short span program, but we got tremendous support from the clinicians and public researchers and interest and demand created in the community. But that was not possible without support. So if we wanted to continue this work, we needed a partner. So we came up with the concept and we give it a nickname that is Stand By Me. So the whole idea of the Stand By Me were twofold. First, we really wanted to revitalize the clinical research platform so that we can promote clinical research in this resource-constrained setting, and also take the leverage of this platform to establish Asian Knowledge Hub so that we'd have wider dissemination of data obtained for COVID-19 and other health data. So our whole objective is to identify challenges at the local level, find out the modalities, how permanent training platform can be built so that we can have a common platform for generating data across many facilities, not just for one population, and use this real-time evidence for identifying solutions. And the whole idea is to strengthen health systems to improve quality of care. But if you think of limiting in one country, that would be a mistake, because the same difficulties and problems are overarching in other countries, particularly in Asian region. So we wanted to outreach to many other countries in Asia and create a similar network, creating disease survey platform so that we can collect information from many institutions at one time and generate solutions for the region and not just for one country. So we believe, so if we collect data in peacetime and in real-time analysis is conducted, we really can support rapid situation analysis and health planning, rapid response to health emergencies. This information is very important for the policymakers because policymakers have not been given opportunity to use data and evidence to formalize their policy in real time or in emergency setting. So if you really want to achieve the SDG goal 3 for ensuring healthy lives and promoting well-being for all at all ages, we just can't work with the health ministry only. We really need to reach out to other ministry. So we need multi-sectoral plans. And how we do it? We need data, we need information. So this is what I wanted to share with you. So you can see there are ample opportunities and there's a huge population who can actually help us providing the solutions, not for the country, but for the region and probably for other regions. And I believe this model can be useful for African and Latin American setting. So that with that, thank you very much.
Thank you very much, Dr. Nahid, for that fantastic presentation and sharing with us the perspectives and the work that you're doing in Bangladesh and the region there. Very, very interesting and very informative. Let me now hand over to Dr. Lorenko. Over to you, Louisa.
Hello, everyone. Thank you so much, Dr. David, for the kind introduction before and for the opportunity to be here today and to be learning so much from all of you. So I'm Louisa. I'm the regional coordinator for CUGH in Brazil. And today I'll be talking to you about some challenges and opportunities to achieve equitable research in Brazil. So as was mentioned before, CUGH is a network focused on capacity building in Latin America and in the Caribbean. And it was built through the European Union Zika Consortia, and it's part of the wider Global Health Network platform. So the main partners of the Zika Consortia here in Brazil were Fiocruz researchers. So very early on, we built this very natural collaboration between CUGH and Fiocruz. So today I want to share with you some of our initiatives that made it possible to be a bit closer to equitable research in Brazil. So before I start with those examples, I really would like to ask you to take a step back and reflect a little bit on the process of health research. So we want health research to be high quality and it to be relevant, right? So we can generate reliable data that will inform future decisions. So when it comes to that process, I brought here this image on the right where you can see some components of this process. And I would like to ask you to reflect what should be our focus when we talk about this process and we want to build equitable health research. So really, we believe that the main answer to this question is we should be focusing on the people involved in this process. So research should be led from the perspective of the community, including both healthcare professionals and the patients. And then obviously, people are involved in this process in several ways. We have people who are contributing with data, people who are generating the data, and we also have people who are doing both things at the same time. And so we have to be focused at what are the needs of the people involved in this process. And recently, we've had a WHO report that actually showed that this is not the case. We're not focusing on the needs of this population. And also, we do not have enough health researchers in low and middle income countries. So really, CUGH and Fiocruz are trying to tackle this problem and asking, how can we bring equity to who benefits, to who is contributing, and to who has access to health research and data. So today I'll bring you some real life examples on how we're doing that. But before, I would like to talk a little bit more about the Fiocruz experience. So Fiocruz is a public health foundation, a Brazilian public health foundation. It is 120 years old, and its mission is to produce, disseminate, and share knowledge and technologies to improve health. So really, the success of Fiocruz is based on 3 building blocks. So the first reason why Fiocruz is such experienced institution here in Brazil is that it is very close to vulnerable communities. So as it was mentioned before, we really need to be focusing on public engagement. And here in this photo, you can see the Fiocruz Castle, which is the Fiocruz headquarters in Rio de Janeiro. And right here behind, you can see this vulnerable community. And it does seem like they're divided by this beautiful jungle, but indeed, the public health, the primary care unit for this population here is inside Fiocruz grounds. So from there, you already see that this amazing institution is really close and related to vulnerable communities around it. Also, Fiocruz is one of the few research institutions in Brazil that have dedicated researcher roles. So this is very important and certainly contributes to the success of this institution. I would like to draw on what Dr. Jacqueline mentioned before. This is really an issue here in Brazil, and Fiocruz is one exception. And certainly the success of this institution is due to that as well. And thirdly, it is really close to policymakers because Fiocruz is linked to the Ministry of Health. Therefore, there is a facilitated flow from information that is discovered in the bench side to reach the offices of lawmakers. So it's really due to these 3 building blocks that Fiocruz has a leading role in the experience of equitable health research. And one example of that is what it's been doing when it comes to the open science movement. So in 2014, Fiocruz launched and implemented open science policy in Fiocruz. And this was built really in partnership with the researchers and with the community. And this has led to the establishment of an online platform where all research undertaken in Fiocruz is shared openly and freely. So building on from this experience, Fiocruz is now trying to make similar policies for ensuring that data sharing and biological sharing and sharing of biological samples are also done following the same principles. So why is it important that Fiocruz is involved in this movement? So actually, it can give a perspective of a low and middle income country to this. So as Dr. Carla mentioned before, we have to be sure that this movement is going to lead to more equitable research instead of to more inequity. Because, for instance, there are some international partners can ask for data and we do not see necessarily the benefits coming back to the society that gave this information. So it's really important to have Fiocruz as a LMIC institution leading this process. So from this example, I hope that I made it clear that it is really the biggest strength of Fiocruz is being able to actively listening the community around it and also their researchers. So if you want to know more about Fiocruz, I ask you to visit fiocruz.tghn.org. So this is a dedicated Fiocruz hub in the Global Health Network platform. And this is where you can find new initiatives. You can find Fiocruz courses. They're all open and free. You can also find highlights of their publications and their COVID response. And this is also where you can reach out to have new partnerships with Fiocruz researchers and your organizations. So I would like to go to one of our examples of a successful story here in Brazil, which was the CUGH 2019 workshop series. So this series was really focused on research capacity buildings and to increase opportunities for both people who already have had experience with health research, but also for people who didn't have experience before. So how did we do that? We actually noticed from the Zika consortia experience that there were several groups in Brazil that had a lot of experience on outbreak research. And this was the case of Fiocruz researchers, but also researchers from other institutions here in Brazil. So what we did was we launched a call for workshops, and this was an initial budget of $10,000, and we selected 5 workshops, all on the field of arboviral diseases. So what we saw there was that we had 239 participants in total, and very interestingly, this was a very mixed group. So we had health researchers taking part of this, but we also had government agents, students and academics, and most importantly, we had members of the public health system users, so members of the wider community participating in these events. So as you can see from the bottom right of my slide, that's a photo of a moment when some children with congenital Zika syndrome and their mothers took part in the event. So this was really a key for the success of this event, this mixed group and the experience that everyone could share and listen from each other. And at registration, we asked the participants to tell a little bit more about their experience, and we found out that 1/3 of those participants did not have previous research experience, and also that more than half of them were attending looking for career development opportunities. So this is really in line with the WHO report data that I showed before, and it really shows that we managed to achieve our target group. So another thing that we asked was to evaluate the impact of these events. So we asked participants to self-evaluate on 5 research skills. And you can see in this radar graph on the right here, you can see those 5 research skills. And the participants evaluated themselves, as you can see in this gray line, before the workshops and in the red line after the workshops. So we managed actually to build, it's a very simple initiative, but it really made a very strong positive impact in this community. And we're sure that we only managed to do that because these initiatives were built in partnership with local teams, with local experts, and it was inviting diverse groups of participants to join. So to end my presentation, I would like to share you a little bit of our Zika findings project. So this is a project in partnership with Fiocruz and the Global Health Network, where the aim is to build a tool to facilitate access to research. So the idea is to have an online platform with built-in artificial intelligence that will be able to translate and make research findings accessible and turn research findings into accessible information. So the idea is that there will be an automated artificial intelligence mechanism that will be able to gather all the information that is on Zika, so both from scientific publications, but also from the gray literature. And they will be able, this artificial intelligence piece will be able to translate this into accessible information, not only to the wider community, but also to researchers from other areas and policymakers. So the idea with this is to really complete a full knowledge cycle and making sure that information goes back to the community that first generated this data. So these are really early steps, but hopefully we'll be able to share a little bit more about this with you in the future. And with that, with those real life examples, I really hoped that you managed to see how important it is to focus on people. And I urge you to rethink about that and to really think what should be the focus that should be given when we talk about health research. So hopefully I convinced you that this is the way forward if we want to generate data that is relevant and that will help us to build a healthier future together. Thank you so much.
Thank you very much, Dr. Louisa, for that excellent case study from Brazil and all the different examples in there. So we now come to the time to take a 10-minute break. Please, it is now 4:28 by my clock, 16:28. So let's be back here at 16:38. Thank you all very much and see you in 10 minutes. Good to see everybody back. So we're going to continue with the session 2, and it gives me great honor and pleasure to welcome Dr. Thomas Nyirenda to present the 3rd case study. Over to you, Thomas. You're muted, Thomas. You need to unmute.
I apologize. Sorry. Thanks, David. I was just saying thanks very much to the organizers of this conference, very important conference, to invite EDCTP to be part and parcel of these very important discussions. So for those who don't know EDCTP, it's an acronym that stands for the European and Developing Countries Clinical Trials Partnership. It is a partnership of African and European member states for deriving interventions through clinical trials and capacity development for infectious diseases that mainly affect developing countries. The main funder is the European Union through the European Commission, and also the member states that are part and parcel of the program, including those that actively participate from sub-Saharan Africa. Just to give you a picture, from 2014 to date, EDCTP has spent close to 800 million euros to support 274 clinical studies in 41 African countries, involving 244 African institutions. This is also including 196 African researchers or researchers based in Africa through fellowship programs, and also support to 39 ethics and regulatory strengthening programs in sub-Saharan Africa in 35 African countries. So as you can see, it's a huge program, and having a lot of investment and a lot of data that has come out of this program. And this is a picture that is probably not just unique to EDCTP, but to many other funders as well. And maybe some of the people in the audience here who are also researchers can resonate with this, that they have been involved with so many funders getting funding to do research, and because they are on project basis, projects close, and the data they have been working on they never have access to it again, they never see it again, and that's it, they move on to a new program or new project. So this has also been a picture in the EDCTP program since we started in 2003, but we have been trying to reverse the situation. And from the outset, we have different programs that we have tried to circumvent this lack of collaboration and sharing. And one of it is what Trudy mentioned earlier, what we call the regional networks of excellence in EDCTP, which are groupings of institutions that receive funding based on their own choice of partnerships, but in 4 regional African demarcations recognized by the Africa Union. So we have one network in East Africa, the other one in Southern Africa, and Central Africa Economic Community has one network, and then the ECOWAS, which is West Africa, has another. And they have been getting EDCTP funding since as early as 2010 up to now. And they have been working together, but even in that kind of setup, there is no efficient systems that are sustainable, that are put in place for sharing information, data, and coming back to it to use it for as a case for future studies. So this is has been a concerning picture. The other program that EDCTP had embarked on, and somebody mentioned it before, was to also establish a clinical trials register in Africa, because there was none before EDCTP was formed. And this clinical trial register, which is now called Pan-African Clinical Trial Register, is at the Medical Research Council, hosted by the Cochrane Group there in Cape Town, and has quite a number of trials now being registered by African researchers or PIs locally. They, of course, they have freedom to register their trials also in other registries that are WHO certified, like the CDC.gov one or the Australian, but we, for the sake of improving visibility and access to data, as we have been discussing, we encourage the grantees that get funding from EDCTP to register their trials in Pan-African Clinical Trial Registry. David has already mentioned our input in regulatory capacity strengthening, which is ABAREF. So all these initiatives are in a way trying to address the same objective. But this hasn't been enough. Up until 5th of July in 2017, when EDCTP became a signatory to the joint statement on public disclosure of results from clinical trials, that we have put a lot of guidance to grantees, those who get EDCTP funding, to start to oblige to certain requirements. And one of the requirements is on open access to scientific publication and research data. So EDCTP is, as I said, is funded by the European Union and is under Horizon 2020 program, and is committed to open access, even from its roots. So open access refers to the practice of providing online access to scientific information that is free of charge, and the end user can also reuse it. And this encompasses, of course, peer-reviewed scientific research articles being published and data being put in repositories, whether through publications or curated data or even raw data. We can discuss about the challenges that are there up to now, but let me go to the second compliance that we insist on, that all EDCTP grantees should show, And this goes to those that are doing research actions against epidemics or public health emergencies. For these actions targeting public health emergencies, the beneficiaries must deposit the digital research data generated in the action in a repository and take measures to make it possible for third parties to use it, mine, exploit, reproduce, disseminate for free of charge for any other user. And most importantly, at the latest, within 30 days after the data has been generated. So again, we can discuss about what challenges we are facing or we may meet on that, but we have taken a step further that although this is not enough, there needs to be a specific initiative that captures all this data for the compliant and non-compliant parties. So in 2019, EDCTP funded the creation of Knowledge Hub by the Global Health Network, whom we have been working with for quite some time now. And this program has led to the development of a management portal and data sharing toolkit. In the process of the development of these resources, there have been several scoping exercises that have been done, mostly literature review based. These have confirmed the challenges that we are discussing here today. And most researchers still feel that the access to data, even if they were involved in the beginning, is not common practice. And now we hope that this Knowledge Hub will be something that will provide a simple and comprehensive tool to the world, at least from what EDCTP has been funding using public money, to give it visibility so that people know how, where, when to access information that they're interested in, whether they are study participants or just interested citizens or scientists or whoever. And so it's something that is new. I'm sure Trudy and colleagues will probably mention about it. We still need feedback. Last November, there was a very fruitful webinar on this that generated some interest and feedback. So in conclusion, from a funder's perspective, as I already said, probably a lot more funders here on the forum, and probably those that are not here are in the same boat as the EDCTP is. This case study shows that it is possible to get from a complete non-access world to somewhere where we can show each other what we are doing, and probably go to this to the extent of enabling us to do things together very quickly, as has been mentioned before. So we are at a very interesting crossroads, and we look forward to the positive changes that are going to happen in this study subject. I would like to stop there, David. Thanks very much for giving me and our organization opportunity to talk about our history and in this aspect.
Thank you very much, Thomas, for that excellent case study that's loaded with a lot of excellent examples. Colleagues, we've had during this session an excellent case study from Bangladesh at the ICCRB, covering the issues of non-communicable diseases, COVID, and exploring how to link data to policy. We have the excellent example from Brazil and the use of Zika and how they are engaging the community there. And now with Thomas, we had these excellent examples of knowledge platforms that have been created to link different actors, including the general public. We've heard about the clinical trial registries. We will have an opportunity to ask questions a little bit later on, just to let you know. So at this point, I would like to thank all the panelists for their excellent presentations, and to hand the mic over back to Dr. Makanga. Thank you all very much.
Thank you very much, David, for chairing this very stimulating session that gives us the real life experiences from the various regions. We'll now move on to the next session. And before we do, at this stage, I want us to reflect a little bit on the key messages that have been coming through since we had the opening of this meeting and through the different panel members. First, we were reminded of the values and trustworthiness being key integral points that have to be considered in the issue of data and getting the best out of the data. And this really reflects that paradigm shift from data ownership to data stewardship. We've had a bit of sharing of information on the landscape in the Honduras, where we're told about the extreme interest that is coming from the, especially from the young researchers out there, and how online courses and virtual tools are playing an important role in equipping this generation of researchers. And then from the African continent, we were updated on the role that the Gates Foundation is doing in partnership with others on strengthening the ethics and regulatory environment, and in this both improving the efficiency and effectiveness of these bodies. I have to say that the European and Developing Countries Clinical Trials Partnership is doing quite a bit of work in partnership with the Gates Foundation in this area. And we were told about the role, and as an example, that the Africa Vaccine Regulators Platform is playing, exemplifying ways of bringing together ethicists, regulators to discuss their priorities, and also setting their key performance indicators with open accountability, and also interacting with product developers, which is key in the generation of highly resourceful data. We had the experience from the Pan Americas, where we had the experience from the Latin America, that is Central America and South America and the Caribbean area, learning from the Zika experience, and also from the COVID-19 experience with the challenges of the new variants coming on, introduction of new interventions, and how they are catalyzing ethical research. But key here was their approach to sharing and anticipating future needs, promoting fair sharing of data. And this goes with the development of local capacity, empowering the communities and the researchers to be part and parcel of this. And then we had the experience from the from Southeast Asia, from Bangladesh, where this was a little bit of a shift from what we are seeing in the African continent, where we have growth in the very youthful population, individuals that are below the age of 30. In Bangladesh, we're told that soon they'll be having lots of people above the age of 60 with a growing degree of multi-morbidity, sitting around 34%. And what came out here was that although it is important to get data from health and demographic surveillance systems, there is a need for comprehensive health data that is in real time, and also bridging that gap of the health workforce to be able to generate good quality data. Then we had the experience from South America, where we had the experience from Brazil, Frio Cruz, who shared their experience in promoting high quality, relevant health research data, giving the example of their reaching out to vulnerable populations, their closeness to the community, bridging that confidence, the dedication of their researchers, contributing to that as well, and the proximity of the researchers or the product developers that are involved in research and development to the policymakers, helping that translation of data into policy and practice. And then interestingly, there was that cycle, completing the cycle, the full knowledge cycle, where they are bringing in the element of artificial intelligence, citing the example of the learnings from Zika, making sure that the data that is generated, the results that come out of the research, can be channeled back to the communities that generate the data. And this is one way of bridging that confidence. And lastly, we've just heard from the European Developing Countries Clinical Trials Partnership, the experience in Sub-Saharan Africa, where capacity is being developed, both developing the expertise of the people, developing the infrastructure, and promoting networking through clinical research networks, and linking this, the research communities, with the regulators and ethicists, and linking them with the policymakers. And the other point that came out here is the need for regional cooperation, linking the countries with the regional players. Now, this is part of the confidence building that promotes international sharing of data, knowing that diseases know no boundaries. With that summary, I would now like us to go into the next part of this, this session, which is very, very exciting. This is now where I want to call upon, I'll be calling upon all the panelists, but before doing so, we have a poll question that I want all of you to pay attention to. A poll question, please. This is from the list, please select what you believe to be the greatest hurdle when sharing data with other researchers. We have lack of infrastructure, lack of data management personnel, lack of incentive to share, governance issues, concerns that recognition will not be given to the researchers who have generated the data in the first place, or rather. Hosts and panelists may not vote here, but this is open to all the participants. How is it playing out? We have governance issues coming out strong at 22%, lack of incentives to share, 13%, lack of infrastructure, 12%, concern that recognition will not be given to the researchers who generated the data in the first place, 10%, and lack of data management personnel, sitting at 8%. And all the above, 31%. That's good. Thank you very much. We now move on to our next and very exciting part of this session. This is session 3, where we have an open panel. And in this panel, I want to call upon all that have been involved. This includes Dr. Jacqueline Alga, Professor Trudy Lang, Dr. Louisa Lorenko, Professor Andrew Morris, Dr. David Mukanga, Dr. Alia Nahid, Dr. Pacific Ndishimie, Dr. Thomas Nyirenda, and Dr. Karia Suens. These are our panelists, and we have them all lined up. And I want this session to be very, very interactive. I'm going to be giving you an opportunity to pose your questions. And as you get ready, I'll pose first questions to our panelists. Our dear panelists, based on everything that we've had today and your own experiences, what do you think are the areas we need to prioritize to enable equitably harnessing the power of data? Let us give the opportunity to the ladies first. Carla, do you want to go first?
Yes. Well, I think that the little survey a moment ago helped us frame this in the best way. I've been thinking since we started, we're dealing with two big words, data and sharing. So to transform our conversation that has been immensely rich into, as it were, like actionable items for us to move forward, we need to do some work now. So I was thinking that governance, so we need to ensure the ethical governance of research data. And I think that one thing that we could do is to think about a table when we have the 4 steps that are, as it were, the life of data. And then on the other axis, we can have the relevant actors and think what can be done to strengthen the governance system from the moment of the collection of data, the storage, let me see, I'm missing, the storage of data, the use of data that includes sharing, and the return of data. So if we think what is missing and what actions are there for each of these steps that unfortunately are not independent, because the first one may rely on what you offer in terms of return, and the actors, then we can think of how we strengthen this governance that people have said is the greatest barrier.
Thank you very much for that, for those insights. Louisa, do you want to give us your take on this?
Hi, thank you for the opportunity. So I totally agree with Dr. Carla. And as I mentioned in my talk, I think really focusing on how can we make people closer to the process of research. So I think really understanding the needs of the population, because sometimes, you know, it was really interesting from the experience that we had in the workshops where the participants were there. And some people were talking about, you know, how useful it is to have wheelchairs for the kids from the congenital Zika syndrome. And they said, we don't have money to buy a wheelchair. So, you know, sometimes we don't know what are the questions. So what can we do to help this population that doesn't have a wheelchair? Can we build on what are the questions we should be asking? So I really think that even for data to be shared before that, it has to be relevant. So we really need to be able to understand the needs of the population and what is the data that should be shared first.
Thank you very much. And Alia, the Southeast Asia experience may be a little bit different. What's your take on this?
Yeah, thank you. This is a great question. So my experience with, of course, Bangladesh and other countries, South Asia. So there is lack of appreciation of research data because all health is primarily being catered by mostly clinicians. And the concept is treating a disease, not an individual. So you know that they dominate the health domain, and data is basically the responsibility of public health researchers, and who really don't have a good dialogue with the clinicians. So when you talk about the health data, probably we do better when you look at the community setting. But health is integrally related with clinical work, right? You know, so my perspective is that we probably need to empower our institutions, even small hospitals, to create a data hub for themselves, because this data is not for creating a large database to share with the global community or writing papers for publication, but also using this evidence to understand the problem in their own setting and identifying the low-cost solutions for them. And if this culture can be introduced, that using local data for identifying solutions and changing policies and maybe systems approach for healthcare, that could be an eye-opener for everyone. And what is totally missing in most developing countries, I believe, is using research evidence for making policy, which is so important. So that is my take. Thank you.
Thank you very much indeed. And what is very exciting about this session is that it's not only about identifying the long laundry list of challenges, but it is very solution oriented. And looking at this, moving on to the other side of the gender group, what do you think are the greatest hurdles to making this happen? What can be done to overcome them? Here we're talking about equitable harnessing of data. What do you think are the greatest hurdles for making this happen? And what can be done to overcome them? If I may ask David, David, what do you think are the greatest hurdles here?
No, thank you very much. And I think I would like to very much agree with the audience and the panelists. I think governance is a key issue that needs to be addressed. And secondly, I think somebody did mention the issue around the data and the type of data and how you package it, you know, depending on the audience that you're talking to. I think for me, I would flag those two areas. And on the governance side, you know, a lot of the colleagues really work with the communities and have very ably articulated the issues there. I would lift it up a little bit to the regulatory and ethics groups that we work with, you know, in our efforts to bring efficiencies in that space. Can we also think about how, you know, the institutional review boards in your institutions, if they've done an ethics review, are they willing to share that report with another IRB, you know, that could rely on that report rather than repeating that work? You know, regulators that have done work, you know, this also I think will need some governance and some discussions around that to propel that that work going forward. It's not necessarily data to be absorbed, but data that will help others within that environment improve their work and bring efficiencies there. Thanks.
Thank you very much, David. And if I may ask Thomas. Thomas, from your experience, what are the greatest hurdles to making this happen, and what can be done to overcome them? You may share the ADCP experience or your personal experience in working with this region or even other places.
Thanks very much, Michael. So, in my opinion, I think I agree with what the others have said, but coming to the technical side, I think it's high time we thought very critically about issues, for example, of having regional data centers of excellence, because we do this very well with laboratories, and we have supranational or regional laboratories that set standards, and they put, you know, information collection tools that are standardized, which probably is not happening in data management. So when you have people collecting data in different softwares, and some of them is encrypted, and all that kind of stuff, and you know how it is stored, and there's no one to regulate that. Again, to ask them to share it may be a pointless exercise, because wherever it's going, it may not be interpretable, and nobody can see it. They're using a wrong gadget, or in a form that is not usable. And I think, talking on behalf of funders like EDCTP and others, I think this is an area to think carefully on how to invest, because these will be centers that we can also build capacities in terms of developing human resources that can, for example, the African continent really needs. We are talking about data, like, is something that is easily managed. But going around the African continent, then you realize when you go around research centers that there is no skill of people who are able to handle and guide the sites on how to collect the data, store it, and archive it, and use it, and share it with others. So it's something that we need to build up to speed. Capacity building has to be part of it, but also strategically looking at the system and then there should be resources put behind it by different partners, not just funders, but also governments and NGOs and others. So a great coalition is really required, just like we have started in COVID.
Thank you very much, Thomas. That's very insightful. We had the Honduras experience, and also hearing the very youthful population and researchers going digital with all these developments. Jacqueline, what is your take on the greatest hurdles for making this happen in your experience, and how can it be overcome? Over to Jacqueline.
Thank you, Michael. I was thinking about tapping on regional or existing structures. For example, in Central America, we have this Council of Ministry of Health for Central America and the Dominican Republic. They are much willing to hear from academics. So we could tap from these smaller regional groups. We have the Central American and the Dominican Republic IRB network, Institutional Review Board network. So if we, as was mentioned before, trust, we could have a lot of governance structure, but trust needs to build up, and maybe doing small things first and exercising sharing in small projects. I have found out that doing this little by little small projects with support from, for example, the Global Health Network, the Regional Training Center from TDR, WHO, working together, Central America, South America, we have been able to build trust. And we have been able in Honduras to get advice and guidance and to share resources with colleagues from the rest of Central America, Dominican Republic, and Colombia, in CDEIM, this International Center for Medical Research in Cali, Colombia. And so that's a way, operative way to overcome these barriers. Thank you.
Thank you very much, Jacqueline. As I promised, I want this session to be very interactive and to encourage all our participants to pose questions to the panel. Looking at the questions that are posted already, there's a question: how can control management systems on health system from delegation of government sorry, it's not very clear, which affect the health system. How can control management, well, I think this is more on control of management of the health system and how this relates to, no, sorry, the question is not very clear. I'll wait for that to be rephrased. It is, the question is from Firu Usheno, if that question could be rephrased so that we understand it. The next question is, what is the role of ICODA, for example, in the case of Pakistan? No, I think those questions have been cleared. Okay, they say that in the case of Pakistan, they have data identified and they have to share it too, rather than fair sharing of that. How can benefit? Well, this is more about ICODA. If I may ask Andrew, if you may just share a little bit about the bit of data sharing and how this may relate to a country like Pakistan. That may shed more light.
Okay, no, and thank you, Michael. And can I just echo, I thought the presentations we heard today were absolutely terrific. You know, there are outstanding programs globally which have created very, very agile and creative data science hubs. And also what resonated was the commitment to collaboration and openness. So, and for me, just imagine what it would be like if we could join these nodes of excellence together. It would be absolutely terrific. And I think that is one of the founding principles of ICODA, is that it is open, it is collaborative, and what we're trying to do is produce a level playing field with the principle that using health data for research is in the public good and a low barrier to entry. So what ICODA is trying to do, and we're still in the foothills of where we need to be, but what ICODA is doing is providing some tools to enable this, an infrastructure and a platform as a service. So a good example is this international meeting. We had 339 people take part, has been enabled by the internet, and it's been pretty good. I think we've only had one technical hitch. There are now tools, infrastructure, data and service tools that can be provisioned, and means that people don't all need to have one in their backyard, but have control over it as a service. So that is one thing that ICODA is enabling, a so-called research workbench, which will be open for people in every country. The second set of services, and we've touched upon it, is the governance of this is really hard. And a friend of mine, as I talk about governance, says, well, it's just fraught with caution, confusion, and inconsistency. And I think that is a global challenge. So what we're trying to do in an open and collaborative way is to define the policies, the ethics, which enable the trustworthy sharing of data, which hopefully can be useful in whichever country of the world wishes to share data, so that we map a pathway of convergence of good data stewardship. And a framework that I would really value feedback on is the so-called 5 safes framework, where we talk about safe data, working on safe projects, which have been evaluated in the public interest, safe people, so authorized and authenticated researchers, in safe places, because I think the less data travel, the better, and safe outputs. So thinking about how we convene on innovative governance, I think will be an important part of ICODA as well. Finally, I have very fond memories of traveling to Pakistan. I was in Peshawar once and had the great privilege of visiting the northwest frontier province, and I hope to go back one day soon.
Thank you very much, Andrew. Then we have another question that is in the question and answers. How do we develop meaningful public involvement, co-creation in research design in multinational studies? As the panelists reflect on this, I'll give some approaches that the European and developing countries clinical trials partnership has used here. One has been in investment in development of the whole continuum of researchers, starting from junior to the very senior that are providing mentorship, and ensuring that there is well-equipped local capacity to generate meaningful research questions that are locally relevant, but having researchers that are also well-networked globally, such that they are able to think both locally and internationally. They generate data that is relevant locally and applicable internationally, which is key as we see regional data becoming more and more important. But the other thing has been a deliberate effort to promote international cooperation between African countries and research institutions through the regional networks of excellence, and also North-South collaboration, where you have researchers in the North and in the South working collaboratively in research projects and ideas coming from either of the regions. Now with this, I'll open it up to the other panelists. It's an open question. How can we develop meaningful public involvement, co-creation in research design in multinational studies? Anyone who wants to comment on this?
If I may comment, Michael?
Yes, please, go on, Tom.
Yeah, thanks. So that's a very important question. And looking back in the research community, we do have certain sections like what they produced in HIV group, what they call good participatory guidelines. And I think what is required, because EDCTP was involved in inputting that global UNAIDS guideline. What is required, I think, is for us who are now interested in this subject to go back to those kind of guidelines, not to stop at just interesting communities to be study participants, but to include issues of participatory practices in terms of data practices. Quite interestingly, I've learned today about those 5 Fs, but I think those are some of the concepts that can easily go into that document, so that we don't just talk about, we're talking to you so you can, you know what research we're bringing to you, it's good for you, and if you participate, you may help others, but data issues are not addressed. I think we need to have a look at that. Thanks.
Thank you very much, Thomas. We have 5 minutes before we close this session, and I want to focus on the questions that are coming in from our participants. And there is a question here that how can we reach the most remote areas in research of public health? Because remote areas have the highest risk for disease, and tracing in health systems may be problematic. We've had an experience that has been shared from Brazil and also from Bangladesh. If I may start with Louisa, What is your take on this question?
Thank you. So really, I think we need to go to the communities. There is no way out of this. So I think we need to understand that if we don't go there and talk to the people, we will never understand their needs and their problems. So really, we can sit here and think of smart ways and how to do that by artificial intelligence, but really, we will need to go to the remote areas and, you know, make people understand the importance of people who are living there and go there. And, you know, it's really about sensitizing people to the issues that are, even though are remote, they're actually as human as we are. So we really need to go to these places and talk to these people, because sometimes you will not have 100 quotes by the end of your survey, but even one person can help you to understand what is in there. And if you don't go to these remote areas and talk to them, you will never find out. I don't know if it was a bit pessimistic answer, but this is how I see it.
Thank you very much, Louisa. And I'll move on to Alia.
That's a great question, actually. And the question is how we can reach the remote areas. To be very honest, scientists or researchers really do research according to their convenience. We try to avoid those remote areas which are very difficult to reach out. And this is why we need to be a little bit adapting a laborious process. And recently in Bangladesh, we conducted the National Micronutrient Survey all over the countries. And it was the Bureau of Statistics actually who helped us to develop multiple cluster random sampling process to identify representative clusters across the whole country. And it created like at 5 to 7% of these clusters included hard to reach areas, including the coastal areas, hillfront areas, like islands. So, you know, so that mandated the researchers to go to these remote areas and collect data. So when we design, the short answer is, when the researchers actually design a research and identify the research sites, we need to be vigilant and honest about picking up vulnerable groups and remote areas and identify that what proportion of population should be represented in the study sampling. So I think this is the only way we can actually do justice to the entire population. And I totally agree with my previous speaker that even if it is 1%, and if we do not have data from them, we'll not be able to develop a comprehensive health systems or a health care model for any country. Thank you.
Thank you very much. I realize that we have more questions, but we are running short of time, and we've asked quite a number of there is one important question here. How does research gets translated into practice, and how are factors, or which factors or characteristics should one look into maybe having this happen? You know, this is a broad question, and it may have answers from different regions. To be fair, I want to give 1 minute to every panelist to say a word on this. If I may start with Alia.
So my immediate answer would be, involve the policymakers in the very first place when you are discussing the research concept, and buy in their support. So when they are involved,
Sorry, Alia has cut out. Sorry.
Sorry, and they are when you present in the service delivery. So my suggestion would be involve the local stakeholders and the policymakers in the research process at the very beginning. Thank you.
Thank you very much. And if I may ask, David, what's your one-liner on this?
I would, from a donor perspective, I think, first of all, at that level, we really need to be talking a lot more with each other and, feeding what we're hearing from on the ground in terms of what the priorities are, and using those to inform our investments. But, when you come down to the community, I think that has been said, really involving the communities and the policymakers at the country level to really be the engines of research, agenda generation with the researchers. I think that would really, really be helpful, and feeding that all the way up into, the governments to finance, and also the donors and others. Thanks.
Thank you very much. And very briefly, Kala?
Sure. We say that we have the duty to do research because research has social value, because research has the potential to improve the health and well-being of our people. So if we don't complete the circle, and if we don't bring the results of research back to the population, then the very reason that we used to justify the research disappears. So we need to start working on that, and ensuring that we have established mechanisms to inform, to use evidence to inform policy and practice. And one message, this is something that my colleague Ludovic Reveis at PAHO works on, but one thing that has been a lesson that works is that instead of focusing on one single event, on the one time on which we're going to use evidence to inform this policy, how about we go away from that approach and we work on mechanisms so health authorities ensure that every single policy and every single clinical guideline is used on the basis of, is informed by evidence with the appropriate methodology. So I think that's how we should switch this conversation for greater impact.
Right. Thank you very much, Kala. And if I may move on to Jacqueline, your one-liner on this, please.
Well, it comes to my mind, implementation science, implementation research, and how we should have more of implementation research involving all this variety of stakeholders, including all these community members, different groups, listen to them and try to learn why these proven interventions that work in control situation are not working in the real life. And a way to know that is trying to understand the implementation of those interventions. So implementation research. Thank you.
Thank you very much indeed. And Louisa.
So I'm going to give a pragmatic answer. I think we need to seduce them, showing that policies that are based on scientific evidence are more effective and they save money and they will get them more votes. So basically, I think we just need to show them, and maybe, when we go back to the community and understand their problems, we have to go back to them and ask them, what is a problem you have? And show them how to solve that with evidence that is just going to be so much more effective. And maybe this is a way to convince them and seduce them into the movement.
Thank you very much. And Thomas?
So from the African continent, thanks, Michael. One thing that I think we need to still relook at is what are the challenges that the knowledge translation platform model are facing, because that's quite a good model, and it encompasses with what everyone has said here. It's about partnerships. So if you have a knowledge translation platform in a country X, we need to study what are the issues that make it collapse. And I'm sure some of them will be the complexity of looking at data. They don't have expertise there, but if they were linked to systematic reviewers at Cochrane and somebody could facilitate that, it could make their work easy to look at country data and make policies out of it and interpret it well. So it's something that we need to look at. I know WHO were keen on this knowledge translation platforms. There were some that worked very well. They were shining examples, but things tend to collapse as time goes on. But we need really to look at what these issues are. In terms of data, I think there will be a challenge there that we will be interested to help with. Thank you.
Thank you very much, Thomas. And I saved Trudy not for the last, but to ask a little broader question. Trudy, we've learned a lot about the challenges. And we have also had some inspiring and innovative solutions to addressing these challenges. What do you see as the key lessons out of this?
Well, I think, thank you, Michael, for the difficult question. So we've just come through so much today, haven't we, and covered the whole spectrum really, and I think that's the point, that it seems quite overwhelming sometimes when you look at all these challenges. But I think we've heard from so many different comments that panelists have made. If you do actually try and see it as an ecosystem and a whole cycle, then it becomes a bit easier to break it down and see where you can put some interventions in. So we started off talking about the patient and involving the community and making sure you ask the right questions in the first place. Take that whole life cycle of the research, which we've come back to time and time again. So you run a good study that answers the questions that you know is a good study because you checked it with your community and it works in that setting. You gather really good data because you've asked the right question in the right place. And then you take that data that as evidence if you found from your study and turn it into recommendations that go back to the community to implement and make changes in health, which is what it's all about ultimately, isn't it? It's about making the changes that the community originally require. And so I think for me, what's come through all afternoon today is this whole ecosystem of research and that life cycle. And I think if we can think about that interface, which I'm sure we'll come back into a minute, about research in the first place, the data it generates, and it all comes back to the community. And that ecosystem is just crucial. So I think that's, for me, the most important point.
Thank you very much, Trudy. And Andrew, how do you think we can build on this work? And what role do you think you can play in realizing our goal of harnessing the power of data?
So it's a very good question. So I think key messages from me are, firstly, today's research is tomorrow's care. And as a research community, we should challenge ourselves to basically say why this is important to citizens, patients, policymakers, and society. Secondly, to tease out those research questions which are important for policymakers and system leaders. I think that's embodied upon us in terms of how we spend our time and our precious resources. Then the third comment is that I've been struck today not only around the common purpose we have, but also the common challenges. And there is this challenge of demonstrating trustworthiness in terms of a transparent approach to governance of why data are shared for what purpose, but also the benefit share. I think that's been a theme, to ensure that we're really clear, when data are shared, how are the benefits going to be shared in a fair way? And I think collectively we can look at that, involving the publics in everything we do, because at the end of the day, working in the public interest is a primary purpose. And for me, this is about People use the word ecosystem, other people use the word a commons. So a commons is a cultural or natural resource accessible to all members of society. And in many ways, I think what we're trying to do in a trustworthy and transparent way is manage health data for the individual and collective benefit. And I think that is the opportunity we have. And in many ways, the technology is subsidiary, but I think that the technology now isn't the challenge. It's about building the social infrastructure to make this work. And I think looking around the participants of this meeting, I think we've got a fantastic opportunity to do something a bit different.
Thank you very much, Andrew. And with this, I want to thank all our panelists. You'll agree with me that this has been a very, very insightful panel discussion that we've had. I know that there are lots of important questions that have been posed. Be assured that these will be responded to. There are people that are working on them behind the scene and will ensure that all questions are responded to in the feedback that will be provided. So we'll now move on to, in case our co-hosts, Trudy and Andrew, have some last words for us before we close the event. If I may ask Trudy to go first.
That's great. Well, thank you all very much. And I mean, the input we've had from the panelists today has just been absolutely sensational. And we've covered such a lot of ground, a lot of geography, and that whole spectrum of issues that we've heard about today. So we were really delighted to be asked to run this session with you all this afternoon. And this has been quite an experience for us, bringing everybody together, but also bringing the Global Health Network, ICODA and HDR UK together. And we're hoping to set out to try and address some of these things we've talked about today. So Andrew and I, between us, just want to talk through what we're hoping to do from now on. And really, this is all about creating this open global collaboration alliance, working together with everybody. And we've spent 10 years with the Global Health Network forming some of these partnerships that many of us are involved with. And we hope we can take this even further forward now. And this does come back to what we were talking about earlier about having this ecosystem or environment of thinking about what the health gaps are that need a question, having a research study to address those, gathering data in really the broadest possible sense of any type of health research study, but also even real life data and healthcare records, generating evidence, and then being able to look at that huge body of data, whatever form it takes, to be able to get new answers to address some of these health challenges wherever they are in the world. And so bringing together what we're doing with the Global Health Network in terms of trying to embed research in healthcare settings and really having research happen in the first place, to dovetailing that with what HDR UK have been doing and what they've taken forward through ICODA, really brings this all together. And so we want to work to enable research in the first place, and then think about how that can join up with these ideas around doing really quite impressive new analytical approaches to get more answers from this data. And all of this is standing on this bedrock of these FAIR principles you've heard about, building trust, but overall working in these global alliances we want to really strive forward and build on from today. So from my perspective, we're just really delighted to be carrying on our work with all of you, and I'm really grateful for everybody taking part, and also looking forward and forming some new partnerships with the ICODA team and introducing them to many more of the global alliances that we have in place. So I'll pass over to Andrew and see how we can wrap this up with everybody.
No, I think just to echo that, this is a different way of transnational collaboration. and we've got a lot to learn. But personally, I feel very privileged to be working in partnership with so many outstanding colleagues internationally. We don't have all the answers. We'll be reaching out to share international best practice wherever we find it. And we've seen some superb examples of that today. There'll be bumps on the road, but I think collectively, let's try and be a flagship initiative of open, collaborative science on the global scale. So, and I see many great suggestions in the chat. There are many tools out there that we don't need to reinvent. So I think if we can have the ability to enable research, demonstrate trustworthy data stewardship in everything we do, underpinned by the technical infrastructure, data and services to enable this at scale in a reliable and sustainable way, I think we'll do good things for the benefit of patients across the world. So just a huge thank you. And can I just flag the support of the Bill and Melinda Gates Foundation, Mindaru, and many other colleagues, including Agnes Binagua, who I quoted earlier, Martin Murphy, I see is here, he co-chairs our SSAC. This is work in progress, and to quote Alaya, stand by me, or rather stand by us is maybe what we should call it. So I'll maybe finish there. And could I thank you, Michael, for your very urbane chairmanship. It was absolutely fantastic, and thank you. Yes, I'll just echo that, Andrew. I think we've had fantastic chairing from absolute pros. It's really appreciated, because it's quite tough doing this, reading the chats on the side and chairing this quite a large group of speakers. So really thank you very much, everybody on the panel and the chairs. Thank you all as well for contributing for the questions. We've had some really important inputs to this. And just to reassure you, we are going to capture everything that's been contributed today, because we're recording the session and we're also going to be writing a report. And so any of the questions that we didn't get time to tackle within the panel sessions, we've not ignored any. We answered some within the Q&A area, but the rest will be written up within the report and we'll make sure we tackle it. So please keep in touch. As Andrew said, this is just the beginning for us in this new partnership. We'll be looking to work with many of you going forward. So keep in touch and do share this link once we've put it live and have got this recording. And thank you very much again, everybody, for taking part.
Thank you very much, Trudy and Andrew. And at this time, I want to re-echo the vote of thanks to all session chairs, to all our valuable speakers, and to our most esteemed audience for joining us. I'm very sure that the last 170 minutes have truly been very well invested. And we want to inform you that the recording as well as the presentation slides will be made available after the event. And as Trudy has already mentioned, there are many valuable questions that have come through. Those that have not been answered will be responded to. So with this, I want to thank you for your time and attention. All the best. Bye for now.